So hydrocele in the neonate refers to a painless scrotal swelling caused by the accumulation of fluid in the tunica vaginalis, the sac surrounding the testicle. It is common and usually benign condition in the newborn males, often resolving spontaneously. So types of the hydrocele in the neonates, we have the communicating hydrocephalus. So there is patent processus vaginalis allows the peritoneal fluid to enter the scrotum and communication with the peritoneal cavity. Non-communicating hydrocephalus, so fluid trapped in the tunica vaginalis and the processus vaginalis is closed and it does not have communication with the peritoneal cavity. And hydrocele of the cord, so there is fluid accumulate collection along the spermatic cord and there is variable communication with the peritoneal cavity. So embryology inside during the fetal development, the testes descend through the inguinal canal into the scrotum, dragging a peritoneal extension, the processus vaginalis. Normally this closes after the descent. If it remains patent, the peritoneal fluid can pass into the scrotum, leading to the communicating hydrocele. If it closes incompletely, the fluid gets trapped, leading to the non-communicating hydrocele. So we have the scrotal swelling, which is a painless, soft, fluctuant mass, unilateral or bilateral either. Transillumination, positive light passes through the fluid, changes with the scrying and the straining, so may increase in the size, especially the communicating. No tenderness or the redness, it differentiates from the infection. So the diagnosis is clinical examination is usually sufficient, transillumination test and ultrasound if the diagnosis is uncertain or to rule out the hernia or the testicular pathology. So for less than 1 year, the management would be observed. Most resolve spontaneously, especially the non-communicating. Greater than 1 year on increasing size, so there's surgical referral leading to the hydrolectomy. Communicating hydrocele often requires surgery due to risk of the hernia. So when to worry or refer or worry, so it persists beyond 12 to 18 months, becomes tense, painless or erythematous, cannot distinguish from the inguinal hernia and rapid increase in the size. So hydrocele versus the inguinal hernia. So we have the hydrocele is not reducible. The cuff impulse is absent. The transillumination is positive. Contents include the fluid and risk of strangulation is none. For the inguinal hernia we have, which is usually reducible. The cuff impulse is present. Transillumination is negative. And the contents include the bowel or the omentum and the risk of strangulation is there. So common benign scrotal swelling in the neonates, most resolved by the age of 1 year, and communicating hydroceles may persist or indicate the hernia risk and refer if persistent enlarging or the uncertain diagnosis. So hydrocele in the children is a condition where the fluid accumulates in the scrotum, specifically around the testes within the tunica vaginalis. It presents as a painless scrotal swelling and is generally benign, but in some cases, especially if persistent, it may require the surgical intervention. So painless scrotal swelling is often unilateral and soft fluctuant. Transillumination is positive. The fluid glows when the light is shined through. Swelling size may increase during the day or with crying and straining if communicating, and no signs of inflammation differentiates from the infection or the torsion. So communicating versus the non-communicating hydrocele. So we have the processus vaginalis, which is patent open. The non-communicating would be the obliterated closed. Fluid source is the peritoneal cavity. For the non-communicating, it's the tunica vaginalis. The size of fluctuation is there for the communicating, and for the non-communicating, it's none. And risk of hernia is high for the communicating. For the management, we have the surgical repair, and for the non-communicating, so this often resolves and surgery if persistent. So the diagnosis is clinical examination is often sufficient. Transillumination, the light passes through the fluid. Ultrasound if the diagnosis is unclear or to rule out the hernia, torsion, or the tumor. So for less than 1 year, for the non-communicating hydrocele, go for the observation, so most resolved by then. For greater than 1 to 2 years, which is persistent, there is surgical repair or the hydrolectomy. And for the communicating hydrocele, there is surgical repair inguinal approach due to the hernia risk. Rapid increase, tense and the painful, so evaluate urgently for the torsion or the incarcerated hernia. So the inguinal hernia is reducible, often extends into the inguinal canal and negative transillumination. Testicular torsion, so there is painful red swollen emergency. Varicocele, so this feels like a bag of worms. So this would be mentioned in your MCQs when they want to hint toward the varicocele. And this is more common in the adolescents and left-sided. We have the spermatic cord cyst, so this is mobile along the cord, may be hard to differentiate from the cord hydrocele. So hydroceles are common and usually benign. So most non-communicating hydroceles resolve spontaneously by the age of 1 to 2 years, communicating hydrocele should be surgically corrected due to the risk of hernia. Diagnosis is typically clinical. Transillumination is helpful. Ultrasound if the doubt exists or the atypical presentation. Meconium in the neonates refers to the first stool passed by a newborn, typically within the first 24 to 48 hours of life. It is a thick, streaky, greenish-black substance composed of the materials the infant ingests while in utero. Composition of the meconium, we have the intestinal epithelial cells, lingua or the fine hair, mucus, amniotic fluids, bile pigments, water. It is sterile, no bacteria, and the odorless. So normal passage of the meconium, so less than 24 hours, this is normal in the term neonates. For greater than 24 hours, maybe delayed passage warrants the evaluation. So delayed passage of the meconium, red flag if not passed within 24 to 48 hours, especially in the term neonates. Differential diagnosis for the delayed meconium passage, Hirschsprung disease, failure to pass the meconium, abdominal distension, and the tight rectum, meconium ileus associated with the cystic fibrosis, thick, sticky mucus causing the obstruction, anal atresia, imperforate anus, absent abnormal anal opening, small left colon syndrome seen in the infant of the diabetic mothers, and hypothyroidism. So there would be generalized hypotonia and the delayed stooling, neuronal or the spinal defects. So this is associated with the neurogenic bowel and prematurity. So there is immature gut motility. Meconium stained amniotic fluid. So this occurs when the fetus passes the meconium in the utero, usually due to the stress and the hypoxia, seen in 12% of the deliveries. Risk factor for the meconium aspiration syndrome. Meconium aspiration syndrome, so inhalation of the meconium stained amniotic fluid into the lungs causing the respiratory distress. Features include the grunting, tachypnea, nasal flaring, and the cyanosis, coarse crackles on the auscultation, patchy infiltrates on the chest X-ray. Management is the supportive care in the form of oxygen, ventilation, antibiotics if the infection suspected, suctioning only if the baby is non-vigorous. So meconium passage is normally presents within the first 24 hours of life. There would be delayed passage of the meconium. Always evaluate the cause in the term infants. Meconium aspiration syndrome. So this is associated with the fetal distress. Meconium ileus. So think of the cystic fibrosis until proven otherwise. For the physical appearance, so there would be greenish, black, tarry, and sticky. Delayed cord clamping in the neonates refers to the intentional delay in the clamping the umbilical cord for a short period of time, typically 30 seconds to 3 minutes, rather than clamping immediately. This practice allows the continued blood flow from the placenta to the newborn, which can improve significant health benefits, especially in the preterm infants. So timing of the cord clamping, so immediate is within 15 to 30 seconds and delayed is 30 seconds to 3 minutes, can vary by the guidelines. So benefit of the delayed cord clamping in the term infants, so increase in the hemoglobin and the iron stores, reduces the risk of the anemia in the infancy, higher blood volumes, better cardiovascular stability, and reduced need for the blood transfusion. In the preterm infants, so there is improved blood pressure and the perfusion, reduced risk of the intraventricular hemorrhage, necrotizing enterocolitis, late onset sepsis, and need for the transfusions. Potential risk and the considerations include the increased risk of the jaundice due to the higher red cell mass, may increase the need for the phototherapy, not recommended in neonatal distress requiring immediate resuscitation, placental abruption or the cord avulsion, and sometimes the twin deliveries case by case. So the recommended delayed cord clamping time for the WHO is at least 1 minute. The American College of Obstetrics and Gynecologists, so they recommend the 30 to 60 minutes seconds for most births. And the American Academy of Pediatrics, so at least 30 to 60 minutes, especially in the preterm. These references are given in your Nelson. We usually follow the American Academy of Pediatrics for this. So EBGAR, we all know, so we'll just quickly revise it. So we have 5 criteria, that is the heart rate, respiratory rate, muscle tone, response to the catheter in the nostril tested after the oropharynx is cleared, and the color. So the heart rate, if we would assign a 0 score if it's absent, if below 100 we offer 1, and if over 100 we give 2. If the respiratory effort is absent, we give 0. If slow or irregular, we give 1. And if good or crying, we give 2. Muscle tone is limp, some flexion of the extremities for 1, and active motion for 2. Response to the catheter in the nostril, so tested after the oropharynx is clear. So no response, grimace or cough or sneezing. Color, we have the blue or pale and body pink, or the extremities and blue and completely pink. So VERNIX caseola is a white, creamy, cheese-like substance that covers the skin of a fetus during the last trimester of pregnancy and is often present on the newborns at birth. Here's an overview of its key features, functions, and the clinical relevance. So VERNIX is composed of the water 80%, lipids 10%, including the cholesterol, cinamides, and the fatty acids, proteins 10%, including the antimicrobial peptides and the enzymes, desquamated fetal skin cells, sloughed off keratinocytes. Functions, we have the protective barrier, shields the fetal skin from the amniotic fluid, which can be macerating, prevents the skin damage and the dehydration, antimicrobial properties, contain the lysozyme, lactoferrin defensins, and the other agents that help protect against the infections. Temperature regulation may help prevent the heat loss immediately after the birth, and lubrication during the birth so reduces the friction in the birth canal, facilitating delivery. Skin development aids in the maturation of the stratum corneum in the utero. So the clinical relevance would be the presence most abundant between 36 to 38 weeks of gestation, decreases as the fetus approaches the term. Post-term infants greater than 42 weeks often have little to no vernix. Delayed bathing, WHO and the AAP recommended delaying newborn bathing for at least 6 hours, ideally 24 hours, to allow the vernix to remain on the skin due to its protective benefit. Absence of the vernix in the preterm neonates less than 28 weeks and the post-term infants is expected, but in some cases may warrant the evaluation of the gestational age. Do not, to take away for the practice is that do not immediately remove the vernix unless medically necessary. So this is very important. I've heard and seen many pediatricians who, when they receive baby, they are more into the removing the vernix. Remember that vernix is given to a child by the Almighty Allah Pak for protection against different microbes, for protection against trauma. So that has a healthy benefit. So you should clean an infant, but not, to the extent of rubbing it and applying even liquid paraffin for that, because the first step is drying, etc. So encourage the patient to gently massage it into the skin, etc. Recognize that its presence or absence may offer clues about the gestational age and the skin maturity. So this antiseptic skin care in the neonates, so this came as one of the TOACS stations. So the purpose was to prevent the hospital-acquired infection, especially in the preterm or the low birth weight infants whose skin barrier is immature. So the best practice would be the routine bathing, delay first bath at least 6 to 12 hours, 24 hours to maintain the vernix and reduce the hypothermia risk. Cleansing using the mild, non-perfumed soap and the lukewarm water, antiseptics when needed, and chlorhexidine gluconate, which is 0.5 to 1%, is preferred for skin prep before the IV insertion or the procedures, and avoid the frequent use to prevent the skin irritation or the systemic absorption, especially in the preterms. So avoid the alcohol-based antiseptics on the very low birth weight infants. Do not scrub, gently pat the skin dry. This is very important. And umbilical cord, so prevent the omphalitis, umbilical cord infection, which can be life-threatening in the neonates. For the WHO guidelines, so clean institutional births, so dry cord care is recommended. Keep the stump clean and exposed to the air flow. Fold diapers below the stump. This is very important. And no routine application of the substances, high risk settings, home births, poor hygiene, high mortality, neonatal mortality. Apply the chlorhexidine. So chlorhexidine 7.1 solution delivering 4% active to the cord stump daily for the 7 days. So this is very important. Remember this came as one of the past MCQs that you need to apply it for 7 days. And more importantly, that only chlorhexidine is recommended as per Nelson and no spirit swabs, etc. So signs of infection to watch for include the redness, swelling, pus, foul odor, delayed separation greater than 3 weeks, fever, seek the urgent care if the infection is suspected, and practical cord care tips for the patient. So keep it clean and dry. Do not pull the stump off. Let it fall naturally, usually in 5 to 15 days, and no home remedies, for example, the ash, oils, and the turmeric. So for the clean hospital, so the skin mild for the skin care, use the mild soap and the water and the delayed bath. For the cord care, so dry the cord care. For the high infection risk, go for the chlorhexidine for the procedures and daily chlorhexidine application. This is to be done only till the age of 7 days. Preterm infants, so gentle antiseptic use as needed, and chlorhexidine in some guidelines. So criteria for discharge of the healthy term newborn. So this was given as it is as a TOACS station. So normal vital signs including the respiratory rate less than 60 breaths per minute, auxiliary temperature that is 36.5 to 37.4 in the open crib. Physical examination reveals no abnormalities requiring the continued hospitalization, regular urination, stool, at least 2 uneventful successful feedings, and no excessive bleeding 2 hours after the circumcision. Laboratory and the other screening, we go for the maternal syphilis, hepatitis B surface antigen, COVID-19, and the HIV status. Newborn hepatitis B vaccine administered, maternal tetanus toxoid, reduced diphtheria toxoid, COVID-19, and the acellular pertussis, adsorbed Tdap vaccination, maternal influenza vaccination during the flu vaccine, evaluation and the monitoring for the sepsis based on the maternal risk factor, including the GBS colonization, umbilical or the newborn direct Coombs test, and blood type if clinically indicated, expanded newborn metabolic screening, hearing screening, screening for the hypoglycemia, based on the infant risk factors, pulse oximetry screening, screening for the hyperbilirubinemia with management and the follow-up as recommended based on the level of jaundice. Social, so we give the evidence of the parental knowledge, ability, and confidence to care for the baby at home in the form of feeding, normal stool and urine output, cord, skin, and the genital care. Recognition of the illness, which you should tell the parents specifically to look for jaundice, poor feeding, lethargy, fever, etc. Infant safety, car seat, supine sleep position, availability of the family and the physician support, physician follow-up, assessment of the family, environmental, and the social risk factors, substance misuse, history of the child abuse, domestic violence, mental illness, teen mother, homelessness, barriers to follow-up, and source of continuing medical care is identified. So what is the prophylaxis that you can offer to the neonate? So we start with the vitamin K. So this is given 1 mg IM for the term and 0.5 mg IM for the preterm. Within 1 hour of birth, prevent the vitamin K deficiency bleeding. Eye prophylaxis in the form of erythromycin, 0.5% eye ointment, or tetracycline or the chloramphenicol within 1 to 2 hours of birth, prevents the ophthalmia neonatorum and gonococcal or the chlamydial. Hepatitis B vaccine, which is 0.5 ml IM birth dose within 24 hours, prevents the perinatal hepatitis B transmission. BCG vaccine, if applicable, so intradermal, usually 0.05 ml at birth or before discharge, protection against the tuberculosis. And hepatitis B immunoglobulin with hepatitis B vaccine within 12 to 24 hours if the mother is HBs AG positive. So this is passive immunity to prevent the vertical transmission. One important thing to remember is that there was an MCQ in the August exam. So they asked that what vaccine should be administered within the first 24 hours of life. So the answer was the hepatitis B vaccine because the oral polio and the BCG vaccine, so they are recommended to be administered before discharge, but the statement of to be administered within 24 hours is not mentioned. So the newborn screening, so this was also one of the past strokes station. This has come in your Aslam Kichi book. We have the metabolic and the endocrine disorders. So this is performed by the heel prick or the Guthrie test, ideally between 24 to 72 hours of life. Commonly screened for diseases are the congenital hypothyroidism, congenital adrenal hyperplasia, phenylketonuria, galactosemia, glucose 6-phosphatase dehydrogenase deficiency, maple syrup urine disease, cystic fibrosis in some countries. So we have the hearing screening method is the autoacoustic emissions or the auditory brainstem response. So this should be done before discharge, ideally within the first month, and early detection of the hearing loss to allow intervention by 6 months, because most of the time there was a research conducted and it showed that milder forms of the sensory neural hearing loss, they used to go unnoticed before the screening. So, and the critical congenital heart disease screening. So the method would be the pulse oximetry to look for the pre and the post-ductal. So, a good neonatologist would never, pass a newborn screen examination without checking the pulse, pre and the post-ductal oxygen saturation. So this is done after 24 hours of birth. It identifies the critical congenital heart defects requiring the early intervention. So this is to be done first at the when the newborn is being born while receiving the baby, and the next should be attempted at 24 hours of birth. So developmental dysplasia of the hip. So the clinical examination is the Barlow and the autorollini test. The ultrasound is the risk factors or the abnormal examination, breech, family history, and the female. So optional regional screenings, we have the sickle cell disease, thalassemia based on the ethnicity and the region, spinal muscular atrophy, CMV screening if the failed hearing screen, newborn genetic screening panels. So timing is critical for the accuracy of the screening. Parental consent is required in many regions. Follow-up systems must be in place for the abnormal results, and documentation of all the prophylaxis and screening should be done in the child's health record. So this was one of my IMM talks stations. So we had this doll. So we had to tell about the Barlow and the autorollenin test. So the purpose of the Barlow test is to detect the hip instability. The hip be dislocated? And for the autorolony, so we detect the hip dislocation. Can a dislocated hip be reduced? So these are the bases. So for the Barlow, we do the adduct the hip, i.e. bring the thigh towards the midline and apply posterior pressure. So a positive sign would be clunk or dislocation felt as the femoral head slips out of the acetabolism. Interpretation is that the hip is unstable and can be dislocated. So bad, it provokes the dislocation. So autorolony, so it abduct the hip, move the thigh away from the midline and apply the anterior lifting force. So clunk or reduction is felt as the femoral head moves back into the acetabulum. The hip was dislocated and now reducible. So the autorolony means out to in and reduces the dislocation. बार्लो में आपने सबसे पहले हिप्स को अंदर लेके आना है, दोनों इस तरह से पेशेंट की जो हिप्स हैं उनको थाइज हैं उनको इस तरह से इंसर्कल करना है कि आपका जो थंब होगा वो प्यूबिक सिम्फिसिस पे होगा और जो आपकी फिंगर होगी इंडेक्स फिंगर वो टुवर्ड्स दी बैक होगी और उसको करके तो पहले आपने इनिशियली जो है ना वो उसको अंदर की तरफ मूव करना है और फिर आपने उसको थोड़ा सा पोस्टीरियरली मूव करना है. अगर आपको क्लिक नजर आएगा इसका मतलब कि जो फीमर है वो बाहर को जा रहा है, ठीक है. और दिस इज बार्लो और ये एक बैड टेस्ट है कि एक हिप जो है वो इतनी अनस्टेबल है कि वो डिसलोकेट हो रही है. ऑटोरोलिनिन में आपने वहीं पे फिंगर्स लिखने हैं और फिर आपने जो है वो जो हिप्स हैं उनको बाहर की तरफ मूव करके और फिर एंटीरियरली कर लेना है, ठीक है. तो ये आपने मूवमेंट्स याद रखनी है और आपने ऐसे ही परफॉर्म करके बताना है. और ऑटोरोलनी का मतलब ये है कि एक अच्छा इंडिकेटर है कि एक डिसलोकेटेड हिप अगर आपको मिल गई है ऑलरेडी जब बच्चा पैदा हुआ है और आप उसको रिड्यूस कर सकते हैं, इसका मतलब कि आपको सिर्फ कास्टिंग से और सिर्फ जो पब्लिक हार्नेस है पहनने से बच्चा ठीक हो जाएगा और उसके लिए सर्जिकल करेक्शन की जरूरत नहीं है. So how to perform the Barlow maneuver? So place the BB supine with the hips flexed to 90 degree, hold the thigh and gently adduct the hips. Apply the gentle posterior pressure on the knees, and a positive Barlow is when the femoral head dislocates posteriorly. For the ortolani maneuver, so perform the same position, that is hold the thighs in the flexed position, abduct the hips while applying the anterior pressure on the greater trochanters. A positive ortolani is when a dislocated hip reduces with a palpable clunk. Important points is best done in the first 2 to 3 months of life before the hips stiffen. These maneuvers should be gentle. Forced manipulation can cause injury. If positive, refer for the hip ultrasound or a pediatric orthopedic consultation. Risk factors for the DDH. So this was also one of the Viva questions in my talk station. So they asked for the breech, female, firstborn, family history, and the oligohydramnios. So male circumcision, this came quite old once in the talk stations when the interactive station was not very well established. There were few interactive stations, but nonetheless they can turn it into an interactive station. So we'll give it a review from the Nelson. So circumcision is the surgical removal of the foreskin pre-bruise from the penis. It is one of the oldest and the most commonly performed surgical procedures worldwide. So the medical indications, so they are less common in the neonates, that is the phimosis, pathological and not physiological in the infants. Recurrent balanitis or the urinary tract infections, UTIs, paraphimosis, foreskin abnormalities, for example, the BXO or the balanitis xerotica obliterans. As a religious aspect, so the um, circumcision is done in our part of the world, but the medical indications, you need to remember them because they can come in your MCQs as well. There are some MCQs on this in the pre-test and the Rudolph both. So the non-medical indications, so this is common in the Jewish and the Muslim communities, and the cultural and the social, so this is practiced in various regions globally, and the parental preference. Just remember that the pathological phimosis, paraphimosis, recurrent balanitis, urinary tract infections, and foreskin abnormalities, so these are the indications for the male circumcision. So ideal timing, so neonatal period, first few weeks of life is ideal, less complex, fewer complications, faster healing, typically no need for the general anesthesia. This is very, very important. So these are the different types of the circumcisions which are now available. So we have the Gomco clamp. So metal clamp compresses the foreskin before the excision, and this is common in the hospitals. We have the Plasti-Bell device. So this is done very frequently in Pakistan. So a plastic ring is placed under the foreskin, and it falls off in 5 to 8 days, sutureless and less bleeding. And we have the Morgan clamp. So shield protects the glands, and the foreskin is cut. So this is faster, but no view of the glands. So preparation and aftercare. So before confirm the normal anatomy, do not circumcise if hypospadias, epispadias, and decordi. So this is very, very important. This was given in your Aslam Kichi, and this used to be asked when the interactive station was not quite much for the TOACS scenarios. So if a child has hypospadias, epispadias, so you need to tackle it in a different way. On obtain informed parental consent, ensure that the baby is healthy, stable, fed, and passed urine. For the pain control, use the local anesthesia, for example, the dorsal penile nerve block or the MLA cream. Oral sucrose may also be offered for discomfort. And after care, apply the petroleum jelly or the antibiotic ointment. Keep the area clean. Avoid the tight diapers. Monitor for bleeding, infection, or the urinary obstruction. So contraindications include the anatomic abnormalities, for example, the hypospadias, prematurity until stabilized, bleeding disorders, family history of the hemophilia, signs of the infection or the illness or the infection, risk and the complications. So this is rare when done properly, but may include the bleeding, infection, excessive skin removal or the complete removal, meatal stenosis, later complication, and pain if the anesthesia is inadequate. So potential benefit, this reduces the risk of UTIs in the infancy, reduces the risk of STIs including HIV, HPV, HSV, and it reduces the risk of penile cancer and the easier genital hygiene. So that is the reason it is recommended in our religion. So the best age would be within the first few weeks of life. Anesthesia is local plus the comforting measures. Main benefits is the hygiene, UTIs, and the sexually transmitted infection risk reduction. Main risks include the bleeding, infection, and the poor healing. Contraindications include the genital anomalies and the bleeding risk. So please remember the genital anomalies as a contraindication because this is quite frequently tested for your MCQs. So 10 steps to successful parental human milk feeding. So every facility providing the maternal services and care for the newborn infants should accomplish the following: have a written feeding policies that is routinely communicated to the staff and the patients, comply with the WHO restrictions on marketing of the breast milk substitutes, and establish ongoing monitoring and the data management systems. So ensure that the staff has sufficient knowledge, competence, and skills to support the breastfeeding. Discuss the importance and the management of breastfeeding with the pregnant women and their families, facilitate the immediate and the uninterrupted skin-to-skin contact, and helps initiate the breastfeeding as soon as possible after birth, support the mothers to initiate and maintain the breastfeeding and manage the common difficulties, give newborn infants no food or drink other than the breast milk unless medically indicated, and practice rooming in, allow the mothers and the infants to remain together 24 hours a day, support the mothers to recognize and respond to their feeding infants feeding clues, counsel the parents on the use and the risk of the feeding bottle, teach and the pacifiers, coordinate the discharge to ensure the timely access to going support and care. Drugs with the potential for the adverse infant effects during the parental human milk feeding. So this is contraindicated for the amphetamines, anti-neoplastic agents, bromocriptine, chloramphenicol, clozapine, cocaine, cyclophosphamide, doxorubicin, ergots, gold salts, heroin, immunosuppressants, methamphetamine, phencyclidine, radiopharmaceuticals, HYDROCELE. So used with conscience, we have the alcohol, amiodarone, anthraquinones, aspirin, salicylates, laxatives, atropine, beta-adrenergic blocking agents, benzodiazepines, birth control pills, bromides, cascara, codeine, dicumarol, estrogens, hydrocodone, lithium, marijuana, metoclopramide, meperidone, oxycodone, phenobarbital, primidone, and the risperidone. So physiology of the lactation, we have the hormonal control. So the prolactin stimulates the milk production from the alveolar cells. Oxytocin causes the milk ejection, that is the let down reflex by contracting the myoepithelial cells. For the estrogen and progesterone, so prepare the breast during the pregnancy but inhibits lactation until the placenta delivery. So milk production phases, we have the lactogenesis during one with mid-pregnancy, colostrum production begins. Lactogenesis 2, 2 to 5 days postpartum and onset of the copious milk. And the lactogenesis 3, which is the maintenance and ongoing milk production through the supply-demand feedback. So composition of the human milk, we have the water, which is important for the hydration, the lactose, which is important source of energy and promotes the gut flora, fat, which is the main energy source and it helps in the brain development, proteins, for example, the casein, whey, and the lactoferrin, immune protection, digestion aid, immunoglobulin, especially the IgA, mucosal immunity, cells or the macrophages, lymphocytes, immune defense, growth factors, which is the GI and the brain development. So colostrum, which is comes in the days 1 to 3. So this is thick, yellowish, high in the IgA, leukocytes, proteins, acts as a natural vaccine. Benefits of the breastfeeding include the decreased risk of infection, which is the diarrhea, pneumonia, otitis media, decreased risk of the SIDS, allergies, asthma, obesity, promotes the neurodevelopment, enhances the bonding and the attachment. So mothers will have the decreased risk of the postpartum hemorrhage while the oxytocin aids the uterine involution, decreased risk of the breast and ovarian cancer, type 2 diabetes, and natural conception, so the lactation amenorrhea method or the LAM. So we have the breastfeeding technique, which is the positioning baby's head and the body aligned, baby's tummy facing the mother, nose to nipple latching, that is the attachment. Baby takes in a large proportion of the areola, mouth wide open, lips flanged outwards, chin and the nose touching the breast. Effective suckling, so deep rhythmic jaw movements, audible swallowing, no clicking or the nipple pain. So the feeding schedule is on-demand feeding, usually 8 to 12 times for 24 hours. No fixed intervals. Every 2 to 3 hours is typical for neonates. Allow the baby to empty one breast before switching, and signs of the adequate feeding. So the urine output is greater than 6 wet diapers per day by day 5, and stool is yellow and seedy by day 5, which is very important. And baby is alert, gaining weight, feeding well, and birth weight is regained by 10 to 14 days. So what can be the problems while latching? So there could be engorgement, there would be milk stasis, frequent stasis feedings and the warm compressive, sore nipples, which is the poor latch and correct positioning and the latch, mastitis, so there is infection, continue the breastfeeding, antibiotics if needed. And for the blocked duct, go for the milk backup, massage, feeding, warm compress. Low supply, that is the ineffective emptying, frequent feeds, pump stimulation, nipple confusion, which is the early bottle use, and avoid the pacifiers in the first weeks. So contraindications to the breastfeeding, we have the infant contraindications, which include the galactosemia, and the maternal, which are the absolute one. And HIV, if the safe formula is available. However, in our part of the world where there is bottle issues of poor bottle hygiene and the low grade formula, so we can even advise breastfeeding while the mother is taking the antiretrovirals. Untreated active TB, human T lymphocytic virus 1 and 2 infection, illicit drug use, chemotherapy, radiation, and most maternal infections, for example, the COVID-19, hepatitis B, C, are not contraindications with the precautions. So storage of the expressed breast milk, this is also given in your heel toques, and this comes quite frequently for the toques. So at the room temperature less than 25 degrees, so you can store it for 4 to 6 hours, and in the refrigerator for 4 degrees, so you can store it for 4 to 5 days. For the freezer, that is minus 18 degrees, so you can freeze for 3 to 6 months. So summary of the infectious agents detected in the human milk and the newborn disease. So the infectious agent, that is the bacteria Mastitis staph aureus, detected in the human milk. Human milk reported as a cause of the newborn disease. And parental infection contraindication to the human milk feeding. So no unless the breast abscess is present. For the Mycobacterium tuberculosis, yes, it is also detected in the human milk. And parental infection and contraindication to the human milk, yes, because of the aerosol spread or the tuberculosis mastitis. And so if the PPD test result is positive and the chest X-ray findings are negative, so then there is no contraindication to the breastfeeding. That is the reason we go for the chest X-ray after to a mother who was reported as TB positive, because that is what causes the risk of transfer to the neonate because of the aerosol spread. So E. coli and the other gram negatives, if stored. So poor hygiene, not washing hands properly. So because the E. coli is bacteria of the stool. So if the mother is not very particular about hand washing, so there could be E. coli sepsis resulting from spread of from the breast milk. Likewise, the group B streptococci can spread the Listeria monocytogenes or the Coxiella brunetti. And syphilis, no, it's not transmitted. And the HIV, so this depends on the location and the therapy. Ideally, both the parent and the child on the retroviral therapy. In developed countries, many recommend not to breastfeed, while in the resource-limited countries, the breastfeeding is encouraged. So likewise for cytomegalovirus, so this is transmitted through the term infants, and the preterm infants evaluate on an individual basis, but risk is increased. For the hepatitis B virus, so yes, surface antigen, and no for the developed country. Hepatitis C, hepatitis E, human T, leukemia virus, also HTLV, herpes simplex virus, rubella wild type, vaccine, varicella zoster virus, Epstein-Barr virus, human herpes virus, so no, HHV6, so yes, Zika virus, Ebola virus, COVID-19, and the toxoplasma plasma gondii for the parasite, so this is also transmitted. So selected factors associated with the high-risk pregnancy. So we have the pre-existing health conditions in the form of anemia, sickle cell anemia, iron deficiency, autoimmune disease, for example, the lupus, inflammatory bowel disease, chronic hypertension, depression, diabetes. Heart disease, congenital or acquired kidney disease, obesity, organ transplant, polycystic ovarian syndrome, substance use disorder, thyroid disease, viral infections, for example, the HIV, hepatitis B, hepatitis C, maternal factors, so the axis, delayed, absent, or too prenatal care, you uninsured, advanced maternal age greater than 35 years, and high risk if greater than 40 years, alcohol, drug, medication, cigarette use, infertility, short interpregnancy interval less than 18 months between the pregnancies, and prior preterm births, fetal anomaly or the fetal demise, tobacco use, and the young age. So we have the fetal factors in the form of the aneuploidy, congenital anomalies, fetal growth restriction, multiple pregnancy, twin triplets, higher order multiples, obstructive complications in the form of breech, presentation, gestational diabetes, hypertensive disorders of the pregnancy, including the preeclampsia, oligohydramnios or the polyhydramnios, placenta accreta spectrum, placenta previa, placental abruption, preterm premature rupture of membranes, which is the PROM, and the preterm labor. So maternal and the obstetric conditions affecting the fetus or the neonate. So we have the antiphospholipid antibody syndrome, so low birth weight or the preterm birth weight, cholestasis for the preterm birth weight, chronic hypertension, which is the IUGR, preterm birth, and the antihypertensive exposure, congenital heart disease. So we have the congenital heart disease, preterm birth, or the IUGR, diabetes, uncertain if the increased risk, large for gestational age, brachial plexus injury, neonatal hypoglycemia, and the neonatal hyperbilirubinemia. Diabetes or the pre-gestational LGA or the IUGR with the maternal vascular disease, congenital anomalies, brachial plexus injuries, neonatal hypoglycemia, neonatal hyperbilirubinemia, Graves' disease, so they would be the low birth weight, fetal thyrotoxicosis, and neonatal Graves' disease, congenital anomalies related to the thioamide exposure, and hypertensive disorders of the pregnancy, gestational hypertension, preeclampsia and eclampsia, low birth weight, and the preterm birth. So we have the hypothyroidism, which is poorly controlled, uncertain if the increased risk, low birth weight, impaired neuropsychological development, HIV or the AIDS, preterm births, congenital HIV, congenital anomalies associated with the some antiretroviral medications, hematological abnormalities associated with some antiretroviral medications, idiopathic thrombocytopenic purpura, possibly increased risk, thrombocytopenia, intracranial hemorrhage, preterm birth, in vitro fertilization, we have the multiple pregnancy. Congenital anomalies, renal disease, chronic, preterm birth, and the low birth weight. Sickle cell anemia, we have the sickle cell anemia if the father is affected or carrier, preterm birth, low birth weight, substance use disorders, congenital anomalies, alcohol, low birth weight, neonatal abstinence syndrome, which is the opioids, systemic lupus erythematosus, low birth weight, neonatal lupus, including the rash and the congenital heart block. So additional maternal conditions affecting the fetus or the newborn. So there is assisted reproductive technology in the form of Bequid, Biedman, Russell Silver, Angelman syndromes, or the altered imprinting, autoantibody against the folate receptors, which is the neural tube defects, blockage of the cellular uptake of the folate, cervical neoplasia, preterm premature rupture of membrane, and the preterm birth associated with the loop electrosurgical excision procedure or the cone therapy. Endemic goiter, we have the hypothyroidism and the iodine deficiency. Herpes gestations, which is the bullous rash, intrauterine fetal device. Autoantibody similar to that in the bullous pemphigoid, and hyperparathyroidism for the neonatal hypocalcemia. Maternal calcium crosses to the fetus and suppresses the fetal parathyroid gland. So we have the isoimmune neutropenia or the thrombocytopenia. Neutropenia or thrombocytopenia, specific anti-fetus neutrophil or the platelet antibody crosses the placenta after sensitization of the mother. Malignant melanoma or placental or the fetal tumors. Placental metastasis, myasthenia gravis, which is the transient neonatal myasthenia. IgG antibody to the acetylcholine receptor crosses the placenta. Myotonic dystrophy, we have the neonatal myotonic dystrophy. Congenital contractures, respiratory insufficiency for the genetic anticipation. NMDAR antibody encephalitis, cortical dysplasias or the transplacental antibody. Obesity, we have the LGA or the IUGR or the hypoglycemia, unknown similarities to the diabetes. Phenylketonuria, microcephaly or the cognitive impairment, elevated fetal phenylalanine values, poor nutrition, which is the IUGR, adult insulin resistance, reduced fetal nutrients, nutritional programming, renal transplantation, which is the IUGR, uteroplacental insufficiency, rhesus or the other blood group sensitization, fetal anemia, hypoalbuminemia, hydrops, neonatal jaundice, IgG crosses the placenta and is directed to the fetal cells with the antigens. So high risk pregnancies in the neonates. So this was also one of the talk sessions. So this is a phrase that needs a bit of clarification, since the neonates refer to the newborn infants typically within the first 28 years of life, whereas high risk pregnancies refer to the complications during pregnancy that affect the fetus and the pregnant person. So what is a high risk pregnancy? A high risk pregnancy is one in which the health or life of the pregnant individual, the fetus, or both is at risk due to the medical, obstetric, and the environmental factors. This definition is very, very important. So this was asked, I think, 2 or 3 years ago in the talks, and this what I heard was that many of the candidates, they were saying that a high risk pregnancy is one in which the fetus or the child is at risk. So you need to mention that the pregnant individual as well. So this may not concern us, but this is important to mention as a part of your definition. So maternal age less than 17 or greater than 35, pre-existing conditions, for example, the diabetes, hypertension, lupus, pregnancy complications in the form of the preeclampsia, placental abruption, multiple gestations, which is the twins and the triplets, fetal abnormalities, history of the preterm birth or the miscarriage, infections, we have the torch infections or the HIV. So neonatal consequences of the high-risk pregnancies, we have the prematurity, birth before 37 weeks of gestation, complications, we have the respiratory distress syndrome due to the surfactant deficiency, intraventricular hemorrhage, necrotizing enterocolitis, hypothermia, and the sepsis risk. Intrauterine growth restriction, IUGR. So definition is the poor fetal growth due to the placental insufficiency or the maternal condition. So the neonatal risk would be the low birth weight, hypoglycemia, hypoxia, asphyxia, developmental delays, congenital anomalies. So this is associated with the poor maternal control of conditions like diabetes, infections, teratogen exposure. Common issues. So we have the neural tube defects, cardiac malformations, and the genitourinary abnormalities. Birth asphyxia is often related to the obstructed bladder, placental obstruction, or the prolonged ischemic encephalopathy, seizures, multi-organ dysfunction, neonatal infection from the vertical transmission during the pregnancy or the deliveries. Examples include the group B, streptococcus, HSV, HIV, and the cytomegalovirus. So the neonatal hypoglycemia, this is common in the infants of the diabetic mother due to the islet cell hyperplasia. Symptoms include the jitteriness, seizures, apnea, poor feeding, hyperbilirubinemia, especially in cases of the RH incompatibility or the prematurity, and risk of the conductress if untreated. So management and the monitoring, we have the prenatal care, early detection and the monitoring via the ultrasonography, fetal Dopplers and the maternal screening, delivery planning, timing, location of the delivery in a center with the NICU support, neonatal care, which is the intensive support, may include the NICU admission, respiratory support, IV nutrition, antibiotics, antivirals, developmental follow-up. So additional maternal conditions affecting the fetus or the neonates. So assisted reproductive technology, that is the Beakford-Friedman, Russell-Silver, Engelmann syndromes, altered imprinting, which is the antibody against the folate receptors, which is the neural tube defects, blockage of the cellular uptake of the folate, cervical neoplasia, so preterm, premature rupture of the membranes, preterm birth, associated with the loop, electrosurgical excision procedure or the cone therapy, endemic goiter, we have the hypothyroidism or the iodine deficiency, herpes gestationis, so bullous rash, intrauterine fetal device, antibody similar to that in the bullous pemphigoid, hyperparathyroidism, so the neonatal hypocalcemia, maternal calcium crosses to the fetus and suppresses the fetal parathyroid gland, isoimmune neutropenia or the thrombocytopenia, so the neutropenia or the thrombocytopenia specific anti-fetus neutrophil or the platelet antibody crosses the placenta after sensitization of the mother. Malignant melanoma, which is the placental or the fetal tumor, placental metastasis, myasthenia gravis. So we have the transient neonatal myasthenia, IgG antibodies to the acetylcholine receptor crosses the placenta. So the myasthenia gravis, there is transient neonatal myasthenia, IgG antibody to the acetylcholine receptor crosses the placenta. Myotonic dystrophy, neonatal myotonic dystrophy, congenital contractures, respiratory insufficiency, and the genetic anticipation, NMDAR antibody encephalitis, cortical dysplasia, transplacental antibodies, obesity, which is the LGA or the IUGR or the hypoglycemia, unknown similarities to the diabetes, phenylketonuria, we have the microcephaly or the cognitive impairment, elevated fetal phenylalanine values, poor nutrition, IUGR, adult insulin resistance, reduced fetal nutrients, nutritional programming, renal transplantation, we have the IUGR or the uteroplacental insufficiency, rhesus or the other blood group sensitization, fetal anemia, hypoalbuminemia, hydrops, neonatal jaundice, IgG crosses the placenta and is directed to the fetal antigen cells with the antigens. So maternal and the obstetric conditions affecting the fetus and the or the neonate. So the antiphospholipid antibody syndrome, low birth weight and the preterm birth, cholestasis or the preterm birth, chronic hypertension. We have the IUGR preterm birth, antihypertensive exposure, congenital heart disease. We have the congenital heart disease preterm birth, IUGR diabetes. Uncertain if increased risk, we have the large for gestational age, brachial plexus injury, neonatal hypoglycemia, neonatal hyperbilirubinemia, diabetes or the pre-gestational LGA or the IUGR with the maternal vascular disease, congenital anomalies, brachial plexus injuries, neonatal hypoglycemia or the neonatal hyperbilirubinemia, Graves' disease, we have the low birth weight, fetal thyrotoxicosis, neonatal Graves' disease 1 to 5%, and the congenital anomalies related to the thiamide exposure. So the hypertensive disorders of the pregnancy, gestational hypertension, preeclampsia and eclampsia, we have the low birth weight, the preterm birth, hypothyroidism is poorly controlled, low birth weight, impaired neuropsychological development, HIV or the AIDS, we have the preterm birth, congenital HIV, congenital anomalies associated with the some antiretroviral medications, hematological abnormalities associated with the some antiretroviral medications, idiopathic thrombocytopenic purpura, so possibly increased risk in the form of thrombocytopenia, intracranial hemorrhage or the preterm birth, in vitro fertilization, so multiple pregnancy, congenital anomalies, renal disease, which is the preterm birth, low birth weight, sickle cell anemia, that is the sickle cell anemia if the father is carrier or affected preterm birth, low birth weight, substance abuse use disorder, we have the congenital anomalies, which is the alcohol, low birth weight, neonatal abstinence syndrome, opioids, and the systemic lupus erythematosus, low birth weight, neonatal lupus, including the rash and the congenital heart block. So polyhydramnios and the neonatal risk. So what is the polyhydramnios? So definition is the amniotic fluid index of AFI of greater than 25 centimeter or a single deepest pocket of greater than 8 centimeters. So this is very, very important. So in your clinical practice, you would be receiving multiple calls from the gynecology department that, the AFI is around 17, it's 18. It's obviously the gynecologist to take it normal is between 10 to almost 16. But remember that the polyhydramnios, which causes risk to the fetus, is greater than 25 centimeter. This was one of the past MCQs as well. So mild polyhydramnios would be 25 to 29.9 centimeter, moderate would be 30 to 34.9 centimeter, and the severe AFI would be greater than the 35 centimeter. So neonatal risk of the polyhydramnios, so there is a risk of the preterm birth, excess fluid stretches the uterus, increases the risk of the preterm labor, premature rupture of the membranes, which is the pre-prom birth defects. Polyhydramnios is associated with the underlying fetal abnormalities in up to 20 to 40% of the cases. Neurological, we have the anencephaly, impaired swallowing reflex. Gastrointestinal, we have the esophageal or the duodenal atresia, tracheoesophageal fistula, genetic syndrome, which is the trisomy 21, 18, and 13, skeletal dysplasias, neonatal respiratory distress due to the prematurity or the lung immaturity, sometimes worsened by the associated symptoms, for example, the diaphragmatic hernia. So the umbilical cord prolapse, so this is common in cases with the abnormal fetal presentations or the high fluid volume, can lead to the fetal hypoxia, emergency cesarean section, neurological injury, fetal malpresentation, breach, or the transverse lie, more likely to due to the excessive room in the uterus, may require the operative delay. Macrosomia or the growth restriction may reflect the underlying maternal diabetes, leading to the fetal macrosomia or placental insufficiency in some cases, leading to the IUGR. Perinatal mortality in the severe or the unmonitored cases, polyhydramnios increases the risk of the stillbirths and the neonatal death, often due to the congenital anomalies or the prematurity. Evaluation of the neonate after the birth. Neonates born from the polyhydramnios pregnancies are often closely monitored for the respiratory effort, blood glucose level, especially if the maternal diabetes was present, feeding difficulties, imaged or tested for suspected anomalies, especially if the prenatal findings were inconclusive. For example, the abdominal X-rays for the bowel obstruction. Preterm births, we have uterine overdistension, congenital anomalies, impaired fetal swallowing or genetic issues. Respiratory distress, we have the prematurity or the related anomalies. Cord prolapse, that is the high fluid volume and the malpresentation. And malpresentation, so too much space in the uterus. Hypoglycemia, often related to the maternal diabetes. And neonatal death, so severe anomalies or the birth complications. So oligohydramnios in the pregnancy, the neonatal risk, so amniotic fluid index of less than 5 centimeter, and the single depicts pocket of less than 2 centimeter. So causes of the oligohydramnios could be the maternal dehydration, preeclampsia, hypertension, and the diabetes. For the placenta, it could be the placental insufficiency, postpartum pregnancy, IUGR. Fetal is the renal agenesis, urinary tract obstruction, chromosomal anomalies, or the ruptured membrane. Neonatal risk from the hypo-oligohydramnios, pulmonary hypoplasia, most severe complications if the oligohydramnios occurs early in the pregnancy. Amniotic fluid is essential for the lung development, can result in the respiratory failure at birth, high neonatal mortality, musculoskeletal deformities due to the restricted fetal movements, clubfoot or the TP's equinovarus, joint contractures or the arthrogyropoiesis, facial flattening, which is the Porter facies. So cord compression, so decreased cushioning can lead to the variable decelerations on the fetal monitoring, fetal hypoxia, emergency delivery, often the C-section, growth restriction or the IUGR, often due to the placental insufficiency, which also causes the low fluid associated with the low birth weight, hypoglycemia, temperature instability, developmental delays, preterm birth or the stillbirth. Oligohydramnios may lead to the indicated preterm delivery, increased risk of the stillbirth, especially in the postterm pregnancies. So the neonatal asphyxia from the prolonged cord compression or the placental insufficiency may result in the low Apgar scores, need for the resuscitation, hypoxic ischemic encephalopathy, postnatal evaluation for the neonates, respiratory support if the pulmonary hypoplasia is suspected, renal ultrasound if the urinary tract anomalies or the renal genesis is suspected, neurological assessment if there was suspected fetal distress or the asphyxia, growth charting, and the glucose monitoring in the IUGR babies. So the neonatal risk would be the pulmonary hyperplasia. Remember that this is one of the most commonly occurring MCQs in your Rudolph and your QBank. So there is reduced lung fluid expansion in the utero, musculoskeletal deformities, there is restricted movement in the low fluid, cord compression and the asphyxia, loss of the amniotic cushioning, growth restrictions, we have the placental insufficiency, Preterm birth, so we have the arthrogenic delivery due to the complications, and stillbirth, so there is chronic hypoxia or the underlying anomaly. So timing is critical. We have the early onset oligohydramnios, especially less than 24 weeks, has worse prognosis than the late onset cases. So maternal infections affecting the fetus or the newborn. So we have the group B streptococcus, which is ascending cervical sepsis pneumonia, E. coli ascending cervical sepsis pneumonia, Listeria monocytogenes, which is the transplacental sepsis and pneumonia, Mycoplasma hominis ascending cervical pneumonia, Chlamydia trachomatis, which is the vaginal passage for the conjunctivitis pneumonia. In syphilis, we have the transplacental or the vaginal passage, congenital syphilis. Neisseria gonorrhea is also spread by the vaginal passage. So there could be the ophthalmia, conjunctivitis, sepsis, and the meningitis. Mycobacterium tuberculosis, or there could be the transplacental prematurity, fetal demise, and the congenital tuberculosis. So we have the rubella, cytomegalovirus, and the HIV, all of which spread by the transplacental. Breast milk is rare, vaginal passage, and the breast milk. So we have the congenital rubella, congenital cytomegalovirus, or the asymptomatic, congenital or the acquired immunodeficiency syndrome for the hepatitis B. So there is vaginal passage, transplacental breast milk, neonatal hepatitis, chronic hepatitis B, surface antigen carrier state. Rarely, the neonatal hepatitis 5% chronic carrier state is possible. And herpes simplex type 2 or 1. So we have the intrapartum exposure, neonatal herpes simplex virus, neonatal encephalitis, disseminated viremia, or the cutaneous infection. So we have the varicella zoster virus. So there's transplacental early congenital anomalies and late neonatal varicella. Parvovirus, we have the transplacental or the fetal anomalies or the hydrops. Coxsackie virus, so there's fecal-oral in the form of myocarditis, meningitis, and the hepatitis. Rubella, we have the transplacental or the abortion and the fetal measles. West Nile, we have the transplacental, uncertain possible rash or the encephalitis, possible perinatal. We have the Zika virus, which is the transplacental, chikungunya, transplacental, dengue, transplacental or the perinatal, congenital microcephaly, intracranial calcifications, brain anomalies, retinal lesions, neonatal encephalitis, neonatal sepsis like the symptoms. We have the toxoplasmosis and the malaria, which is the transplacental, congenital toxoplasmosis, abortion, prematurity, intrauterine growth restriction. We have the candida or the ascending cervical sepsis, pneumonia, and the rash. Recommended perinatal, fetal, and the maternal screening tests and the preventive care. So we have the first trimester blood type and the antibody screen, complete blood count, syphilis screen, VDRL or the rapid plasma reagent or the treponemal test, urine analysis or the urine culture, hepatitis B surface antigen, HIV, chlamydia, gonorrhea, rubella immunity, offered carrier screen for at-risk populations, offered ultrasonography dates, offered cell-free DNA, second, third trimester. We have the diabetes screen between 24 to 28 weeks, complete blood count, quad screen. We have the alpha-fetoprotein, estriol, human gonadotrophin, inhibin, alpha-RH antibody screen, Group B streptococcus, Tdap, and the seasonal influenza vaccinations, and offered fetal structural ultrasound between 18 to 22 weeks. So conditions associated with disorders of the amniotic fluid volume, we have the oligohydramnios, so there could be the uteroplacental insufficiency in the form of fetal growth restriction, preeclampsia, twin transfusion donor, placental abruption or the chronic arthrogyroposis, including the fetal akinesia deformation syndrome. Others, we have the amniotic fluid leak, rupture of the membranes, fetal GU obstruction, which is the bladder outlet obstruction, fetal renal failure, bilateral renal agenesis, multicystic dysplastic kidneys, indomethacin, angiotensin converting enzyme inhibitors or the receptor antagonists, polyhydramnios, impaired swelling or the obstruction, neuromuscular CNS abnormalities, and arthrogyroposis, including the fetal akinesia deformation sequence or the spina bifida. So the GI obstruction, we have the tracheoesophageal fistula, intestinal atresia, diaphragmatic hernia, thoracic masses. Craniofacial, we have the cleft lip or the palate, micrograthia, neck masses, excessive urine production. Renal or the urinary, we have the post-obstructive diuresis, for example, the UPGA obstruction, Bartter syndrome. Cardiac, we have the cardiac structure anomalies, tachycardia, sacrococcygeal teratoma, and the chorangioma. Osmotic diuresis, we have the diabetes mellitus, twin transfusion recipient, hydrops, immune or non-immune, and the idiopathic. So for the fetal growth and the maturity, so we have the fetal growth phases and milestone. Fetal growth is not nearly linear. It occurs in the distinct phases. So the first trimester, that is 0 to 12 weeks. So we have the cell division, organ formation, and the organogenesis. 8 centimeters, 25 grams by the week 12. Second, with the 13 to 27 weeks, rapid length, growth, limb, and skeletal development. 36 weeks, 900 grams by week 28. And third, we have the 28 to 40 grams weight gain and the organ maturation, 50 centimeters, 3 to 3.5 grams at the term. So the organ system growth highlights. So the heart starts beating around week 6. Lungs would develop alveoli after week 24. Surfactant production begins around week 28, matures in week 34 to 36. Kidneys would function by the week 9 to 10. Urine contributes to the amniotic fluid and brain. So there would be the rapid development in the third trimester. Liver would be immature at birth and limited ability to conjugate the bilirubin. So fetal maturity and the functional readiness for the life outside of the womb. Fetal maturity refers to the organ readiness, not just the size or the gestational age. So the lungs, so they would be the surfactant production, that is the lecithin sphingomyelin ratio greater than 2:1, increases the risk of the respiratory distress. Neurological coordinated sucking, swallowing 34 to 36 weeks. Readiness for the oral feeding. Gastrointestinal, so the meconium is present in the bowel by 12 weeks and mature motility around 36 weeks. Risk of the feeding intolerance in the preterms. Skin becomes less transparent and more ketonized by the 37 weeks. Thin skin in the preterm increases the fluid loss. Thermoregulation. So brown fat stores increase by 32 to 36 weeks. Helps maintain the body temperature. So classification by the growth and the maturity. So the SGA, or the small for the gestational age. So that means that weight of less than 10th percentile. All of these MCQs have come in your past. So these definitions are very, very important. So the risk would be the hypoglycemia and the temperature instability. So AGA, which is the appropriate for the gestational age. So weight is between the 10th to 90th centiles. So normal outcome is expected. So that's why it is also recommended that we plot the height, weight, and OFC of a child just afterwards, so we can classify as per that and anticipate the risks that could occur. So we have the LGA, or the large for gestation age, so weight greater than the 90th centile, birth injuries, and the hypoglycemia. Preterm, we have less than 37 weeks, immature lungs, and the feeding issues. Term, which is 37 to 41 plus 6. So optimal survival and the maturity. Post term, we have the 42 weeks, so meconium aspiration and the aging placenta. Fetal growth increases in the size and the weight, feature maturity, functional development of the organs. Optimal outcome depend on both the adequate growth and the organ system maturity, especially in the lungs and the brain. So fetal distress refers to the sign before or during the childbirth, indicating that the fetus is not well, typically due to inadequate oxygen, hypoxia, or the acidosis. It requires prompt recognition and the management to prevent the perinatal complications or birth. So definition would be the fetal distress is a non-specific term indicating the fetal compromise, often due to the hypoxemia, low oxygen in the blood, hypoxia, low oxygen in the tissues, acidosis due to the buildup of the CO2 and the lactic acid. So causes of the fetal distress, we have the maternal factors in the form of the hypotension, preeclampsia, eclampsia, uterine hyperstimulation, infection, we have the chorioamnionitis, diabetes or the anemia, placental factors, we have the placental abruption, placenta previa, uteroplacental insufficiency or the post-term pregnancy. Fetal factors, we have the cord prolapse, intrauterine growth restriction, IUGR, congenital anomalies, multiple gestation, or the oligohydramnios. Signs of the fetal distress, so abnormal fetal heart rate patterns monitored by the CTG and the NST. So we have the tachycardia greater than 160 beats per minute. So there's infection, hypoxia, and the drugs. We have the bradycardia less than 110 beats per minute. Cord compression and the hypoxia, late deceleration, which is the uteroplacental insufficiency, variable deceleration in the form of the umbilical cord compression, and the loss of variability, that is the CNS decompression and the severe hypoxia. Meconium strained amniotic fluid, so signs of the fetal distress, especially if the thick or in early labor, risk of the meconium aspiration syndrome, decreased or absent fetal movements, often reported by the mother, may indicate the fetal hypoxia or the compromise. Biophysical profile score of less than 4, this was also one of the past MCQs, so combines the ultrasound and the neonatal stress test for a total score of 10, assess the movement, tone, breathing, fluid, and the reactivity. So neonatal deaths from the fetal distress, we have the birth asphyxia, which is the hypoxic ischemic encephalopathy, low Apgar score, multi-organ dysfunction, meconium aspiration syndrome, and the neonatal death in the severe untreated cases. So we have the cause in the form of the hypoxia, acidosis, cord, and the placental problem. Signs, we have the abnormal fetal heart rate, meconium, decreased movement. Diagnosis is the CTG, BPP, Doppler, fetal scalp pH. Management is the reposition, oxygen, fluid, possible delivery. Neonatal risk is the asphyxia, HI, MAS, TOACS, and the deco admission. So fetal diagnosis and the management. So the imaging would be the ultrasound, real-time biometry, growth, abnormal detection, including the congenital heart disease, GI, CNS, skeletal number of the fetuses, sites of the calcification, biophysical profile. So we have the amniotic fluid, volume, hydrops, velocimetries, blood flow velocity, detection of the increased vascular resistance in the umbilical artery secondary to the placental insufficiency, detection of the fetal anemia, which is the MCA Doppler, defining of the lesions before the fetal surgery, and better delineation of the fetal CNS anatomy via the MRI. So the fluid analysis by the amniocentesis, so karyotyping or the microarray cytogenetics, biochemical enzyme analysis, molecular genetic DNA diagnosis or the alpha fetoprotein determination, blood culture, pathogen and antigen or the genome detection, which is the PCR, cordosynthesis, which is the percutaneous umbilical cord sampling, detection of the blood type, anemia, hemoglobinopathy, thrombocytopenia, polycythemia, acidosis, hypoxia, thrombocytopenia, IgM antibody response to the infection, rapid karyotype, and the molecular DNA genetic diagnosis, and the fetal therapy, fetal tissue analysis, which is the chorionic villus biopsy, cytogenetic, and the molecular DNA analysis, enzyme assays, circulating fetal DNA, cell-free DNA, non-invasive molecular DNA genetic analysis, including the microarray analysis or the chromosome number or the screening method. So maternal serum alpha fetoprotein concentration, so that is elevated, which is the twins, neural tube defects, anencephaly, spina bifida, intestinal atresia, hepatitis, nephrosis, fetal demise, incorrect gestational age, trisomies, aneuploidy, maternal cervix, so there is fetal fibronectin indicates the possible risk of preterm death, transvaginal cervical length, so short length indicates, suggests the possible risk of the preterm birth, bacterial culture, so identifies the risk of the neonatal infection in the form of the group B, Streptococcus, Neisseria, gonorrhea, and the chlamydia trachomatis, and determination of the PROM. Antepartal biophysical monitoring, so the non-stress test detects the fetal distress and the hypoxia. So the biophysical profile and the modified biophysical profile, so this detects again the fetal distress and the hypoxia, and intrapartum fetal heart rate monitoring. So biophysical profile score technique and the interpretation. So this I think came also very old sometimes in the talks. It hasn't come recently, it might come. So we have the fetal breathing movements. So at least one episode of fetal breathing movements of at least 30-second duration in 30-minute observation, and absence of the fetal breathing movements or no episode greater than 30 seconds in 30-meter. Gross body movement, at least 3 discrete body movements, limb movements in 30 minutes, episodes of active continuous movement considered as a single movement, and 2 or fewer episodes of body limb movement in 30 minutes. Fetal tone, at least one episode of active extension with return to the flexion of the fetal limb or the trunk, opening and closing of the hand considered evidence of the normal tone. Either slow extension with return to the partial flexion, or movement of the limb in full extension or absence of the fetal movement with the hand held in complete or partial deflection. The active fetal heart rate, so at least 2 episodes of the fetal heart rate, acceleration of greater than 15 breaths per minute, beat per minute, at least 15 seconds in duration associated with the fetal movement in 30 minutes, and less than 2 episodes of acceleration of fetal heart rate or acceleration of less than 15 breaths per minute in 30 minutes. We have the quantitative amniotic fluid volume, at least 1 pocket of the air that measures at least 2 centimeter and 2 perpendicular plane, either of no amniotic fluid pockets or the pocket less than 2 centimeter. As we know, this was a definition for the oligohydramnios in 2 perpendicular planes. So characteristics of the deceleration of the fetal heart rate. So we have the late deceleration. This is visually apparent, usually symmetrical, gradual decrease and return of the fetal heart rate associated with the uterine contraction. A gradual fetal heart rate decrease is defined as a duration of greater than 30 seconds from the onset to the nadir of the fetal heart rate. The decrease in the fetal heart rate is calculated from the onset to the nadir of the deceleration. The deceleration is delayed in timing with the nadir of the deceleration occurring after the peak of the contraction. In most cases, the onset, nadir, and the recovery of the deceleration occur after the beginning, peak, and the ending of the contraction, respectively. So the early deceleration, so visual apparent, usually symmetric gradual decrease and return of the fetal heart rate associated with a uterine contraction. A gradual fetal heart rate decrease is defined as duration of greater than 30 seconds from the onset to the fetal heart rate nadir. The decrease in the fetal heart rate is calculated from the onset to the nadir of the deceleration. The nadir of the deceleration occurs at the same time as the peak of the contraction. In most cases, the onset, nadir, and the recovery of the deceleration are coincident with the beginning, peak, and the ending of the contraction. So the variable deceleration, this is visually apparent, abrupt decrease in the fetal heart rate, and abrupt fetal heart rate 30 seconds from the onset of the deceleration to the beginning of the fetal heart rate, nadir of the deceleration, the onset to the nadir deceleration. The decrease in the fetal heart rate is greater than 15 beats per minute, lasting greater than seconds, and less than 2 minutes in duration when variable decelerations are associated with the uterine contractions. Their onset, depth, and duration commonly vary with the successive uterine contractions. So this is an image showing the early deceleration, the late deceleration, and the variable deceleration. So three type fetal heart rate interpretation system. We have the category 1, which is the fetal heart rate tracing, including all of the following. That is the baseline rate of 110 to 160 beats per minute. Baseline fetal heart rate variability, moderate, late or variable deceleration is absent. Early deceleration is present or absent, and the accelerations are present or absent. The category 2. So the category 2 fetal heart rate tracing includes all the fetal heart tracing not categorized as category 1 or 3. So the category 2 tracings may represent an appreciable fraction of those encountered in the clinical settings. Examples of the category 2 fetal heart rate tracings include any of the following. That is the baseline rate, the bradycardia not accompanied by the absence of the baseline variability, and the tachycardia. So we have the baseline fetal heart rate variability. So minimal baseline fetal heart rate variability, absence of the baseline variability not accompanied by the recurrent decelerations, and marked baseline variability. So accelerations, we have the absence of induced accelerations after the fetal stimulation, periodic or the episodic decelerations, recurrent variable decelerations accompanied by the minimal or the moderate baseline variability, prolonged deceleration of greater than 2 minutes but less than 10 minutes, recurrent late decelerations with moderate baseline variability, variable decelerations with the other characteristics such as the slow return to the baseline, overshoots, and the shoulders. Category 3. So category 3 fetal heart rate tracings include either the absence of the baseline fetal heart rate variability and any of the following in the form of the recurrent late decelerations, recurrent variable deceleration, bradycardia, and the sinusoidal pattern. So this is the maternal disease, the fetal and the neonatal risk associated with it. So we have the diabetes mellitus, which is the pre-existing or the gestational. So the risk could be the macrosomia, increased risk of the birth injury, neonatal hypoglycemia, congenital anomaly, especially the cardiac neural tube, stillbirth, and the respiratory distress syndrome. So a key note is that the strict glucose control reduces the complications. And remember that the insulin does not cross the placenta. Hypertension and the preeclampsia, so the intrauterine growth restriction, IUGR, preterm birth, placental abruption, fetal distress, or the stillbirth. Antihypertensive use must be safe for the fetus, monitoring the uteroplacental blood flow, systemic lupus erythematosus, fetal heart block, especially with the anti-Ro, anti-La antibodies, IUGR, neonatal lupus, preterm birth, require the close fetal echocardiography, monitor the antibody levels. Thyroid disorders, we have the hypo and the hyperthyroidism, growth abnormalities, neurodevelopmental delays, fetal or the neonatal thyroid dysfunction. Treat the maternal thyroid disease early. TSH and the free T4 levels must be monitored. Infections, torch, group, toxoplasmosis, rubella, CMV, HSV, syphilis, microcephaly, hydrocephalus, cataracts, deafness, hepatosplenomegaly, skin lesions, bone anomalies. Risk is highest in the first trimester. Congenital infections often permanent. We have the HIV, which is the vertical transmission. Risk is 15 to 45% untreated. IUGR preterm antiretroviral therapy drastically reduces the transmission. So the chronic kidney disease, we have the IUGR preterm birth or the oligohydramnios stillbirth. Monitor the blood pressure, renal function, risk of the worsening maternal disease, anemia, especially the iron deficiency, so the low birth weight, preterm delivery or the poor neonatal iron store, supplement the iron and the folic acid in all the pregnancies, epilepsy and the anti-epileptic use, so the congenital malformation, especially the neural tube defects, IUGR withdrawal seizure in the neonate, use the lowest effective AED dose, folic acid supplementation is critical. Obesity, so we have the macrosomia, neural tube defects, preeclampsia, gestational diabetes, counsel on the weight management before the pregnancy, and asthma, so the IUGR preterm labor if uncontrolled, hypoxia-related complications, and most inhaled medications are safe. Asthma should be well controlled. We have the phenylketonuria, so microcephaly, congenital heart defects, intellectual disability, maternal dietary control, decreased phenylalanine is crucial before and after during the pregnancy. So substance use, we have the alcohol, tobacco use, fetal alcohol spectrum disorder, which is the IUGR, preterm birth, neonatal abstinence syndrome. So presents with the early counseling and the cessation programs. So infections in the form of the toxoplasmosis, which is the transplacental, increased risk in the third trimester, severity is increased in the first trimester. Hydrocephalus, intracranial calcifications or the chorioretinoitis, avoid the raw meat, cat litter, spiramine for the maternal infections. Rubella, which is the transplacental first trimester highest risk, congenital rubella syndromes, cataract, deafness, heart defects, MMR vaccine before the pregnancy only and not given during the pregnancy. We have cytomegalovirus, which is the transplacental perinatal, any trimester, most severe in the early pregnancy, sensorineural hearing loss, microcephaly, periventricular calcifications, and no vaccine. Hygiene is important. Screen with the torch infections if suspected, and the herpes simplex virus. So during the delivery, contact with the lesions, intrapartum, skin, eye, mouth lesion, encephalitis, disseminated infection, and cesarean is the active lesions. Acyclovir may reduce the recurrence and stillbirth, Hutchinson's syndrome, saddle nose, rash, palm, sore, screen, all the pregnancies and penicillin treatment is affected. For the hepatitis B, we have the perinatal blood and the body fluids at delivery mostly, and chronic hepatitis B and the liver damage risk. Hepatitis B vaccine, HBIG at birth prevents the transmission. HIV, we have the transplacental perinatal breast milk throughout the pregnancy and the breastfeeding, IUGR, preterm neonatal HIV. ART reduces the transmission to less than 2%. Avoid the breastfeeding when where safe. Varicella zoster virus, we have the transplacental or the perinatal. First and second trimester, congenital varicella, perinatal neonatal varicella, limb hypoplasia, skin scars or the CNS defects, varicella zoster virus vaccine before the pregnancy, varicella zoster immunoglobulins if exposed during the pregnancy. Parvovirus B19, we have the transplacental second trimester greatest risk, fetal anemia, hydrocephalus miscarriage, no vaccine monitor with the MCA Doppler for the fetal anemia. The Zika virus, so there is transplacental sexual or the mosquito bite, first trimester microcephaly, brain malformations, and the eye abnormalities. Avoid travel to the Zika endemic areas during the pregnancy. Listeriosis, we have the transplacental any trimester, preterm birth, stillbirth, sepsis, meningitis in the neonates. Avoid the unpasteurized deli meats. Treat with the ampicillin, group B streptococcus. So during the delivery, vaginal canal, intrapartum sepsis, pneumonia, meningitis, and the early or the late onset. Screen at 35 to 37 weeks, intrapartum, penicillin prophylaxis if positive. So factors known to be associated with or a causative at stillbirth. So we have the maternal factors in the form of the socioeconomic status, prior history of the stillbirth, smoking, hypertensive disease, diabetes, advanced maternal age, obesity, maternal anemia, polycythemia, thyroid disorders, both the hypo and the hypothyroidism, systemic lupus erythematosus, chronic renal disease, prescription pain medication, substance use disorders including the alcohol, residential and the occupational toxin exposure, thrombophilias including the anti-phospholipid antibodies, maternal trauma and the maternal infection. So risk factors we have, fetal factors we have the congenital anomalies usually caused by the major chromosomal abnormalities, infections, multiple gestation, twin transfusion syndrome, monoamniotic twinning, fetal growth restriction, metabolic disorders, which is the hemoglobinopathies, glycogen storage disorders, amino aciduria, peroxidase deficiency, immune and the non-immune hydrox. Delivery factors we have the post dates, placental abruption, and the umbilical cord accidents. So agents acting on the pregnant persons that may adversely affect the structure or the function of the fetus and the newborn. So we have the alcohol or the congenital cardiac, CNS, limb anomalies, IUGR, developmental delay, attention deficits, autism, facial ear anomalies, heart disease, CNS abnormalities, ACE inhibitors, angiotensin receptor antagonists. We have the oligohydramnios, IUGR, renal failure or the Potter sequence, azathioprine. We have the neonatal anemia, thrombocytopenia, lymphopenia, carbamazepine. We have the neural tube defects, possible neurodevelopmental delays, carbimazole, scalp defects, choanal atresia, esophageal atresia, developmental delay, chorionic villus sampling, possible limb reduction defect if performed before 9 weeks. Cigarette smoking, we have the low birth weight for the gestation age, the orofacial clefts, cocaine crack, placental abruption, possible vascular disruptive effects, tenazole, which is the virilization, hyperthermia, spina bifida, lithium, possibly increased cardiac defects, Epstein anomaly, 6 mercaptopurine, neonatal anemia, thrombocytopenia, lymphopenia, methyl mercury. So we have the Minamata disease, microcephaly, deafness, blindness, intellectual disability, masculinization of the female fetus. And the misoprostoles, we have the arthrogryposis, cranial neuropathies, Mobius syndrome, and the equinovirus. So agents acting on the pregnant persons that may adversely affect the structure or function of the fetus and the newborn. So we have the mycophenolate mofetil, we have the craniofacial limb, cardiovascular defects, spontaneous abortion, norethindrone, which is the masculinization of the female fetus with the large doses. We have the penicillamine, which is the cutis lexa, congenital anomalies, neuroblastoma, bleeding, vitamin K deficiencies. Prednisone, we have the oral cleft. Stilbestrol, we have the clear cell adenocarcinoma of the vagina and the cervix in the adolescent. So we have the streptomycin for the deafness, tetracycline for the pigmentation of the teeth, thalidomide, phocomelia, deafness, and the other malformations. Toluene or the solvent abuse, we have the craniofacial abnormalities, prematurity, and the hypertonia. For the topiramate, we have the cleft lip, trimethadione, and the paramethadione for the spontaneous abortions, multiple malformations, and the cognitive impairment. Valproate or the CNS neural tube defects, facial and the cardiac anomalies, limb defects, impaired neurological functions, autism spectrum disorder. Warfarin or the Coumadin, we have the fetal bleeding and the death, hypoplastic nasal structures, and the stippled epiphysis. So intrauterine diagnosis of the fetal disease. So the purpose is to detect the fetal structural abnormalities, genetic or the chromosomal conditions, infections, growth anomalies before the birth, allowing for early intervention, counseling, or delivery planning. So diagnostic medications and their applications. So this is very commonly asked in your MCQs and your talks. So the ultrasound is done between the first and the third trimester. So it is done for the routine screening, anomalies, dating, and the growth monitoring. Structural anomalies in the form of the neural tube defects, cardiac, GI, IUGR, hydrops, and the twins for the knuckle translucency. So 11 to 13 plus 6, first trimester, aneuploidy screening, trisomy 21, 18, 13 risk when combined with the serum markers. We have the chorionic villus sampling between 10 and 13 weeks, high genetic risk, abnormal screening, which is the karyotyping, single gene disorders, for example, the thalassemia or the TOACS, amniocentesis greater than 15 weeks, abnormal ultrasound screening, advanced maternal age. We have the karyotyping, neural tube defects greater than the AFP, infections, PCR, fetal echocardiography between 18 to 24 weeks, abnormal cardiac views, maternal diabetes, lupus, congenital heart defects, for example, the tetralogy of Fallot or the AVST. We have the maternal serum screening, 11 to 22 weeks, screening for the aneuploidy. Trisomy 21, 18, neural tube defects by the PAPPA, HCG, AFP, inhibin A, or the estriol. We have the cell-free fetal DNA greater than 10 weeks, non-invasive aneuploidy screening in the high-risk mothers, trisomy 21, 18, 13, sex chromosome disorders, fetal MRI between second to third trimester, further evaluation of the ultrasound detected CNS abnormalities, brain malformation, and the diaphragmatic hernia. Cordosynthesis is done greater than 18 weeks, suspected fetal anemia, infections, and the rapid karyotype. Fetal blood sampling for the RH disease, torch infections, and thrombocytopenia. Doppler ultrasound is done greater than 24 weeks for the IUGR, preeclampsia, and the anemia. Uterine artery resistance, MCA, PSV, fetal anemia, and the umbilical flow. Torch screening is done anytime from the maternal blood for the suspected intrauterine infection, toxoplasmosis, rubella, CMV, HSV, and the syphilis. So the common diagnosable fetal conditions, we have the genetic disorders in the form of the Down syndrome, Edwards syndrome, Turner syndrome, structural abnormalities for the anencephaly, spina bifida, cleft lip palate, CHD. Infections, we have the CMV, toxoplasmosis, rubella. Hematological, we have the hemolytic disease, for example, the RH isoimmunization, anemia, growth disorders, IUGR, macrosomia. For example, in the maternal diabetes, metabolic disorders, that is the TOACS, thalassemia, and the cystic fibrosis. So non-invasive tests, we have the ultrasound are the first line for the screening, and the invasive tests, for example, the amniocentesis and the CVS, are used for the definitive diagnosis. Early diagnosis enables the parental counseling, in utero therapy, for example, the transfusions, and the planning the delivery in a tertiary care settings. So significance of the fetal ultrasonographic anatomic findings. So this was also has come in the multiple MCQs. So the dilated cerebral ventricles. So this is by definition ventriculomegaly greater than 10 mm. So this would be seen in the hydrocephalus, hydrancephaly, Dandy Walker cyst, agenesis of the corpus callosum, and the volume DOS. So we have discussed this in our CNS lecture. So we have the transient isolated ventriculomegaly is common and usually benign. Persistent or the progressive ventriculomegaly is more worrisome. Identify the associated cranial and the extracranial anomalies. Serial ultrasound, head ultrasound, or the MRI evaluate for the extracranial anomalies. We have the choroid plexus cyst. So the size would be 10 mm, unilateral or bilateral, 1 to 3% incidence. Abnormal karyotyping, trisomy 18 to 21, increased risk is the AMA. Often isolated benign, resolved by 24 to 28 weeks. Fetus should be examined for the other organ abnormalities. If additional anomalies are present, amniocentesis should be performed for karyotype. Head ultrasound examined for the extracranial abnormalities and the karyotype if indicated. For the knuckle fold thickening, so greater than 6 mm at 15 to 20 weeks, cystic hygroma, trisomy 21 to 18, Turner syndrome, other genetic syndromes, greater than 50% of the affected fetuses have chromosomal abnormalities. Amniocentesis for the karyotype is needed and examined for the multiple organ malformation. Karyotype if indicated, dilated renal pelvis, Phylactesis greater than 4 to 10 millimeter, 0.6 to 1% incidence. Normal variant uteroplacental pelvic junction obstruction, vesico-urethral reflux, posterior urethral valves, ectopic urethrocy, large volume non-obstruction, often non-physiological, and the transient reflux is common if the dilation is greater than 10 mm or associated with the calcitosis. So pathological cause should be considered if larger bladder is present, posterior urethral valves, and the megacystitis, microcolon, hyperperistalsis syndrome should be considered. Repeat the ultrasound on day 5 and at 1 month, avoiding the cystourethrogram and the prophylactic antibiotics. Echogenic bowel, which is 0.6% incidence, which is the cystic fibrosis, meconium peritonitis, trisomy 21 or 18, and the other chromosomal abnormalities, cytomegalovirus, toxoplasmosis, GI obstruction, intrauterine bleeding, fetal swelling or the blood, often normal. Consider the CSF, aneuploidy or the torch, sweat fluoride or the DNA testing, karyotyping, surgery for the torch, evaluation for the torch, and stomach appearance, so absent or small or with the double bubble. Upper GI obstruction, esophageal atresia, double bubble signifies the duodenal atresia, aneuploidy, polyhydramnios, stomach in the chest signifies the diaphragmatic hernia. Must also consider the neurological disorders that reduce the swelling greater than 30% with the double bubble, have trisomy 21, chromosomes, kidney, ureter, bladder radiograph if indicated, and the upper GI series and the neurological evaluation. So we have the fetal therapy, that is the hematological anemia with the hydrops, erythroblastosis fetalis, cordosynthesis of the umbilical vein with the packed red blood cell transfusion, isoimmune thrombocytopenia. So we have the umbilical vein platelet transfusion, maternal IVIGs, maternal steroids, and the IVIGs, which is the autoimmune thrombocytopenia. Metabolic or the endocrine, we have the maternal PKU, phenylalanine restriction, fetal galactosemia, galactose-free diet, multiple carboxylase deficiency, biotin if responsive, and the methylmalonic acidemia. So vitamin B12 if responsive, and the 21 hydroxylase deficiency. So dexamethasone if the female is fetus. Maternal diabetes mellitus, so the tight insulin control during the pregnancy, labor, and the delivery. Maternal hyperthyroidism, which is the maternal propyl hydrocele, fetal goiter, fetal hypothyroidism, which is the intra-amniotic thyroxine. So the Water syndrome, maternal endomethacine may prevent the nephrocalcinosis and the paternal postnatal sodium losses. So we have the fetal distress in the form of the hypoxia, maternal oxygen position changes, intrauterine growth restriction, improve the macronutrients and the micronutrients if deficient, smoking cessation, treatment of the maternal disease, antenatal fetal surveillance, oligohydramnios, premature rupture of the membranes with the variable deceleration. We have the antenatal fetal surveillance approach dependent on the etiology, amnio infusion, intrapartum, antenatal fetal service approach dependent on the etiology, amnio reduction if indicated, maternal digoxin, flecainide, procainamide, amiodarone, quinidine, maternal aspirin, and the heparin for the meconium stained fluid. We can go for the amnio infusion. For the congenital heart block, we can go for the dexamethasone and the pacemaker with the high drops for the premature labor. So magnesium sulfate, nifedipine, indomethacin with the antenatal corticosteroids, which is the betamethasone. So the pulmonary immaturity, we go for the betamethasone. Bilateral chylothorax for the pleural effusion, thoracocentesis, pleuroamniotic shunt, and the severe diaphragmatic hernia, we have the fetoscopic tracheal occlusion. So congenital anomalies would be the neural tube defects, folate, vitamins, prevention, fetal surgery, posterior urethral valves, urethral atresia, lower urinary tract obstruction, percutaneous vesicoamniotic shunt, cystic adenoid malformation with the hydrops, pleuroamniotic shunt or the resection, fetal neck masses secure in airway with the exit procedure. So the infectious disease, we have the group B, streptococcus colonization, ampicillin and the penicillin, chorioamniotis, which is the antibiotics and the delivery, spiramycin, pyrimethamycin, sulfadiazine, and the folic acid. Syphilis, we have the penicillin. Tuberculosis, we have the anti-tuberculosis drugs. Lyme disease, we have the penicillamine or the ceftriaxone. For the parvovirus, we have the intrauterine red blood cell transfusion for the hydrops and the severe anemia. Azithromycin for the chlamydia trachomatis, HIV or the AIDS, so the maternal and the neonatal antiretroviral therapy, and no approved perinatal treatment for the cytomegalovirus. Others, we have the non-immune hydrox, which is the anemia, umbilical vein packed, red blood cell transfusion, narcotic abstinence, which is the withdrawal, maternal methadone maintenance, sacrococcygeal teratoma with the hydrox, in utero resection or the catheter directed vessel obliteration, cardiac rhabdomyoma, maternal sirolimus, intrapericardial teratoma, which is the fetal surgery, twin transfusion syndrome. We have the repeated amniocentesis, aluminium garnet laser photocalculation of the shared vessels, twin reverse arterial perfusion or the trap syndrome, cord occlusion, radiofrequency ablation, multifetal gestation, which is a selective reduction, neonatal hemochromatosis, maternal IVIGs, aortic stenosis, which is the in utero valvuloplasty. So this is a comparison of the chorionic villus sampling, amniocentesis or the chordosynthesis. This has come in your talk station. So the chorionic villus sampling is done between 10 to 13 weeks. Amniocentesis is done after 15 weeks, and the chordosynthesis is done after 18 weeks, but best after 20 weeks. So sample taken for the chorionic villus sampling is the chorionic villi, which is the placental tissue. So the method is the transcervical or the transabdominal needle. So the diagnostic uses the genetic and the chromosomal anomalies. Turnaround time is 1 to 2 weeks. Detection of the neural tube defects. So this is not detected because the no amniotic fluid and the alpha fetoprotein can't be measured. So risk of miscarriage is 0.1 to 1% and higher than the risk of maternal cell contamination is higher than the amniocentesis. And other risks can be the liver abnormalities before 10 weeks, and early diagnosis of the genetic disorders is the main indication, and limitation would be the cannot detect the neural tube defects and the placental mosaicism. So amniocentesis is done after 15 weeks from the amniotic fluid. So transabdominal needle under the ultrasound guidance, genetic, chromosomal, and the neural tube defect infections. So the turnaround time is 1 to 2 weeks faster with the fish. So yes, it can detect the neural tube defects, specifically the by measuring the alpha fetoprotein and the acetylcholinesterase testing. So the risk of miscarriage is 0.1 to 0.3. Risk of the maternal cell contamination would be low. So there would be leakage, infection, fetal injury. Safer, best done used for the safer broad testing, including the neural tube defects. Later timing slower than the NIPT. So we heard the chordosynthesis. So this is done after 18 weeks, best after the 20 weeks. Fetal blood, which is the umbilical vein, Transabdominal needle after the ultrasound guidance, rapid karyotyping, fetal infections and the anemia, 24 to 72 hours rapid results, and not used for the primary use to measure the neural tube defects, and 1 to 2% that is the highest risk. Risk of maternal cell contamination is low, bleeding, bradycardia, preterm labor, urgent fetal blood testing, anemia and infection, and technically demanded higher complication risk. So these are the MCQs which have come. So I've just made it into a table for easy remembrance. The early genetic testing diagnosis in the first trimester, the preferred test is the CVS. For the neural tube defects, for example, the spider bifida, we go for the amniocentesis. The reason is that the neural tube defect is detected by measuring the alpha fetoproteins and the acetylcholinesterase in the amniotic fluid. So while the CVS would be just be taking the maternal placental tissue and not the amniotic fluid itself, so it cannot detect it. We have the suspected fetal anemia or the thrombocytopenia, so go for the chordosynthesis. Rapid fetal karyotyping in the later pregnancy, again go for the chordosynthesis. And the intrauterine infection, for example, the CMV or the toxoplasmosis, so go for the amniocentesis or the chordosynthesis. So CVS allows the early diagnosis but lacks the neural tube defect detection. Amniocentesis is safer and more comprehensive but later, and chordosynthesis is reserved for urgent or complex fetal evaluation due to the high risk. So thank you. This was the end of the lecture.